in Japan, we don't have pain fellowship training program, but we have certified board program in Japan. So the situation of the pain management in Japan is changing. In tradition, most of Japanese pain clinicians specialize in neural block interventional method. Now, the ratio of another method, such as medication, is getting increased. With focusing on the multidisciplinary method for pain management. In this situation, we have just started to establish the pain fellowship training program, and now we are preparing the system. Not yet, but we are just preparing. On this purpose, we have some guidelines for trainees and non-specialists for pain management. Today, I'd like to introduce the newest guideline of our society, which is educationally targeted guideline. So this is one example for our future pain training program. This is the same picture of Shimane Izumo Shrine, which is the oldest shrine in Japan. This is the background of this guideline. Neural blocks such as epidural blocks, such as ganglion block, and peripheral nerve blocks historically are the most popular strategy in pain clinic in Japan. Medication also takes an important role in pain management. The pain medication is getting much more popular, especially opioid use, opioid therapy. Recently, Japanese Society of Pain Clinicians has published 2 important guidelines in pain management. One of them is guidelines for neuropathic pain management, and the last one is guidelines for the pharmacological management of and this is the first one, and the second one is a guideline for prescribing opioid analgesics for chronic non-cancer pain. Today, I'd like to introduce the outline of and the features of this opioid therapy for non-cancer chronic pain patients. Before establishing this guideline, we had important research to demonstrate background of pain medicine in Japan, comparing with another countries, USA and Germany. This research was performed using online research. Subjects is to pain physicians, 9 doctors in each country. Totally 270 doctors. Internal medicine doctor and anesthesiologist, orthopedician. These are patients' characteristics. In each country, 270 patients are entry. These are patient characteristics, and this is a result. This is the first choice for chronic back pain patients. First choice. In all countries, NSAIDs are very popular. And USA and Germany also some variable adjuvant agent like that. This is a second line. In US or Germany, the ratio of opioids, weak and strong opioids use are getting increased, but not in Japan. And also, adjuvant analgesics are much popular in two countries, USA and Germany. This is a third line, third choice. It is a similar situation in third line treatment. This is another disease, PHN. First choice, any countries use NSAIDs, and except Japan, USA, Germany use adjuvant analgesics. And our future is that we use intervention or neural blockade for these patients as the first line. This is the second line. Opioids use are getting increased in USA and Germany, but not in Japan. A third line is a similar tendency. This is the data for CRPS. In this disease, it is similar situation. Opioid and multimodal medication are popular in two countries, USA and Germany. This is the second line, and third line shows similar tendency. This is the data from fibromyalgia patient. These are similar tendency in patient with fibromyalgia. And this is the effect of opioid therapy on quality of life and ADL. Totally, opioid therapy improves pain and also there's appetite 3 and QOL. So opioid therapy is an important role for treating chronic severe pain patients. After this research, this is a summary of this research. In Japan, we don't use medication, especially opioids, as much as the other Western countries. Opioid therapy can opioid therapy can improve patients' QOL as well as pain. After that background, we have just published this guideline last year. Guideline of opioid use for chronic non-cancer pain. Principle of opioid therapy in Japan is here. The basis is to protect chronic pain for opioid therapy is typically nociceptive pain, and neuropathic pain, but not psychological pain is not indication for opioids. It is a very important part. And then start opioids. If it produces good analgesic effect, it can be continued, but not, it should discontinue quickly. And if we have some adverse effect or some problem in social activity, opioids should be discontinued soon. Key of opioid therapy is here. The first one is indication, which is patient selection. This is the indication chart for opioid therapy. The first part is evaluation of patient. Important thing is source of pain, and QOL and ADL, and treatment, and adherence to medication, and psychological, psychosocial aspects. We should exclude this problem and their living environment. Second part is prepare consent form. Important thing is written in red. The starting on that prescribing, adjusting the dose and discontinuing treat is under the direction of a physician, not patient or family. The final object of opioid therapy is to improve QOL, and that the object of opioid therapy is clearly defined. And patients should receive periodical examination every week or every month. And the patient is not being prescribed opioid analgesics by more than one institution, hospital. Various adverse drug reactions can occur from long-term prescription of opioid analgesia. It should be discontinued. The prescription of opioid analgesics is not a treatment that can be continued permanently, not permanently. Regardless of regulation, opioid analgesics are not to be given to another person. This is a checklist for opioid therapy. Check. Compliance with treatment. Check. Degree of pain relief. Check. For adverse drug reactions. Check. Social and life activities. And check mental condition. Check. For environmental changes. And periodically reconfirm the purpose of treatment. This is a risk factor. We should exclude those risk factors like that. History of substance abuse, family history of substance abuse, youth under 45 years old, sexual dependency, mental disease, generalized drug use, psychological stress and abuse of multiple substances, poor living environment, smoking, history of rehabilitation for substance or alcoholic dependency. Interesting in opioids, dysfunction due to pain, excessive complement of pain, complement of pain of unknown origin. The second key for opioid therapy is opioid selection. The important things are from weak opioid, means we should start from weak opioid. And we don't use rescue dose with opioid rescue, we don't use. And we don't use sustained release opioid, we don't. And we should use low risk of dependent opioids first. This is a risk and opioid addiction relationship. This is a weak and this is a strong potential for formulation of dependence. Weak risk include sustained release formulation or transdermal formulation. High risk for dependence is immediate release formulation or intravenous injection, something. Fast releasing method. This is a summary of our guideline. The objectives of the guideline is to provide pain relief and improve the quality of life lived of patients through the appropriate use of opioid analgesics. And second, to protect patients from the harmful effects of opioids when opioids are not used appropriately. And third, to establish and maintain a system for the prescription and use of opioid analgesics in Japan. Opioid therapy for chronic non-cancer pain is not applicable for all patients. It should be restricted to patients who meet the following criteria. Number one, persistent pain that is clearly of organic origin. No effective method for pain relief besides opioid therapy. Patients understand the purpose of opioid therapy and good adherence to medication, especially opioids. No history of substance or alcohol dependence. Psychogenic pain and psychophysiological problem should be ruled out. And second, when initiating opioid therapy for chronic non-cancer pain patients, we conduct a review of other prescribing drugs and consider discontinuing opioid therapy or decreasing the dose independent of their efficacy. And another important thing is we should use long-lasting release opioids, not immediate release opioids. And also, we don't use opioid rescue. It is very important to save use of opioids. And after opioid therapy, regular physical and mental evaluation of the patient must be conducted to determine whether opioid therapy should be continued or not. Thank you very much for your attention.